it's Dr. Shelly with HETV with Shelly's Nursing Review. And because it's a new year coming up, less than 24 hours, y'all see my little exciting little thing I got on my head. Cheers, boo. Cheers. But anyway, it's a new year, so we have lots of new exciting things for you coming up, and so you're going to need to stay tuned to the end of this video when we will tell you some of our new features. I think you will like them. Many of you have been asking, is boot camp online? Well, not quite, but I think you'll want to know what we did to kind of make life a little easier, and going forward you can kind of get a little bit of boot camp in your day just coming to HETV. So anyway, here's the deal, y'all. This video is one of our new features. One of our new playlists that I am making is called Select All That Apply, fill in the blank, right? So this video is Select All That Apply Dehydration. In other words, we're going to give you the select all for risk factors, the select all for causes, the select all for nursing care of the dehydrated patient, the select all for signs and symptoms. That way you are prepared for our HESI, ATI, NGN, NCLEX, whatever. Because I know you guys are ridiculous about Select All That Apply, but remember, in a way, they're the better question to get, because do you remember how this is supposed to go, y'all? Look, you get partial credit now on the Select Alls. So if you know, like I know, if you're positive about what you're selecting, click on it. If you're not at all sure, don't guess, because you get the partial credit for selecting it, but you get a point taken away if you select the wrong thing. So I want to make sure that I prepare your videos for you to pass this NGN NCLEX, because that's where you get the partial credit. Now, whenever I have a chart like this, you know that I put the chart like this to compare and contrast two very similar kinds of issues, right? Two very similar conditions. And whenever I do this chart like this, it means I'm preparing you to answer a case study. So we're handling the select all part of your test, we're handling the case study part of your exam. And so with these two methods of teaching, I think you'll do well. Lastly, you will need this handout. This is the acid-base imbalance. It's also the electrolyte handout and fluid. So in this handout, which is huge, you will see fluid volume excess. You will see deficient fluid volume. You know what I mean? Like this is your fluid volume deficit, like select all type of stuff. And you'll see a bunch of other information on fluid. It also has how you treat it in here with the different fluids you can use, okay? So I need you to make sure you get your handout, all right? Now, if you need any supplies, Oh My God packet, or any of the pink packets, or any of the white packets, you just have to text me, 216-410-0936. Let's get started. Okay, the name of this video again, Select All That Apply for Dehydration. The first step is to realize there's lots and lots and lots of different ways to say dehydration. Maybe your test flat out calls it dehydration. However, some will say fluid volume deficit. Fluid volume deficit. That is very, very common. Maybe they go a little bit further and they say hypovolemia, right? So you don't know. So you have to know that this is a select all for all three of those conditions, which are all the same. Now, let's look at the people who are at risk for dehydration the most. The people at risk for dehydration the most include babies. And please remember that 80% of a baby is water, whereas 60% of adults is water. 80% of this baby is water. So the most common causes of fluid volume deficit or dehydration in babies is diarrhea and vomiting. We don't go more than 24 hours with those guys. And we also like oral rehydration solutions like Pedialyte. You probably know that from pediatrics. Elderly. Oh, I could go on and on and on about the elderly. Well, there's lots of problems with the elderly. Number one, they lose their thirst reflex. They just don't get thirsty. Often we have to teach them to literally lick their lips to feel if their lips are dry. We also have to tell them to notice the color of the urine. If it's dark, you need to drink more. The elderly are at higher risk for dehydration also because of medications that they could be on, especially HCTZ, loop diuretics. Both of these, as you know, are diuretics. They may also be on maybe an ACE inhibitor, which, as you know, encourages the excretion of water. The patient may have dementia, may not even be aware of how or what to do about filling up their body with fluid and keeping themselves well balanced. They just may not be aware. The patient may be institutionalized, which I think is just terrible. And I wish we didn't do as much as we do, because I remember working in long-term care facilities thinking, why is this person here other than their family either turn their back on them or their family doesn't exist, like they're nowhere, like they don't have any family, because these people were just like mildly confused, and it was just sad. So if you have patients that are institutionalized, they're very often reliant on us to give them fluids. So you really want to encourage fluids and have literally water jugs available with fluid in it for our elderly patients. We want to think that way. Push fluids, as long as they don't have any clinical reason why pushing fluids would be harmful. But these two are most at risk. Obviously, our homeless patients, our homeless people, and certainly those patients can come in dehydrated, especially in the summertime. So being homeless is a risk factor for dehydration. Oh, our outside workers, our construction workers, our electricians, whatever you're doing outside, and even athletes to a lesser extent, because athletes usually know how and when to hydrate. But hey, outside workers are very much at risk. So these patients have higher risk for dehydration. And all of that was common sense. Like, I didn't tell you anything you didn't know, right? Okay. Oh, and with the elderly, I did want to point out as well, these patients could also have some renal problems, some kidney problems, and therefore they may or may not be able to really retain the fluid that they need to keep their body hydrated. Now, the causes of dehydration are popular focus areas on everybody's test, whether it's an NCLEX, a HESI, an ATI, nursing school final, whatever it is. The causes of dehydration, and some of the causes are kind of easy. Just say to yourself, she loves the D, because so many of them begin with the D. Now, diarrhea, huge. Remember, everyone, that diarrhea is infectious until you prove it's not. But even non-infectious diarrhea, which is your inflammatory bowel disease, your Crohn's, your ulcerative colitis, those are diarrheas that are putting the patient at risk for dehydration. Just that incredible loss of GI fluid is profound for these patients. But infectious diarrhea, your Shigella, your giardiasis, your salmonella, your norovirus, your rotavirus in babies, your cholera, with the natural disasters, all of these diarrheas that you may or may not even be familiar with, these put the patients at risk for dehydration. Vomiting, you already know this. What do we say about these two things? Don't go more than 24 hours vomiting or having diarrhea before you seek attention. So if it's been a whole day, a whole 24 hours, you haven't kept anything down or in, you need to be seen. And the other thing, I know it's going to sound weird because we're saying diarrhea is so dehydrating, you do not want to use antidiarrheals with infectious diarrhea. Unless it's an inflammatory bowel disease, which is Crohn's or ulcerative colitis, you don't want to use anti-diarrheas with diarrhea that is infectious, because it's better out than in. It's just that if it's coming out more than 24 hours, your patient needs to be seen. Okay, diuretics. This is a big one because so many patients are on these medications, especially hydrochlorothiazide, which we usually say HCTZ. Remember, HCTZ is the first line drug of choice for hypertension. So there's a lot of people on these medications. You already know that loop diuretics will cause you to pee every 20 minutes for a few hours. So these diuretics and even laxatives can make our patient at higher risk for dehydration. Maybe even your ACE inhibitors to a lesser extent, just because they encourage the release of fluid after getting rid of the sodium. A lesser extent, a greater extent. Now, DKA and DI. DKA, diabetic ketone acidosis. When I say the word diabetic, right away you know the sugar is really high. This patient is very sick. Sometimes their DKA was triggered by an infection. Sometimes it's just because they never knew they were a diabetic, and this is their first episode at the hospital for us to tell them the reason why your sugar is 900 is because you're a type 1 diabetic who maybe wasn't diagnosed before. And these patients with DKA have polyuria. Remember the 3 P's? Poly. Polyuria is first. You're peeing and peeing and peeing, 20 liters of fluid a day. How much do you and I pee? 2 liters, maybe 3 max, but they're peeing out 10 to 20 liters a day. So polyuria. Well, when you're peeing that much, you're going to get what? Polydipsia. Dipping in the water to catch a drink. Dipsia, polydipsia. Polydipsia is excessive thirst, right? And then polyphagia. DI also has polyuria, and with DI, everything is decreased, right? So the only thing that's not decreased is polyuria and sodium. Okay, so with DI, which has to do with, endocrine, diabetes insipidus, not diabetes mellitus, but diabetes insipidus, you're peeing out 20 liters of fluid with that too. So both DKA and DI have polyuria, all right? Gastric decompression is a tricky one. Be careful on the test. We are not talking about enteral feedings or an NG tube for enteral feedings. We're talking about a Salem sump for gastric decompression, which means you have either pancreatitis or severe nausea and vomiting or bowel obstruction or some other thing where we're trying to keep your belly from being distended and collecting fluid. And so we go ahead and we slip an NG tube, a nasal gastric tube down, and we're using it to keep the belly compressed, right? Decompression. We don't want this, we want this with this patient. Maybe it was recent surgery. Who knows? The bottom line is it's not an enteral feeding. Okay, no, it's for decompression. So we're not even talking about a core pack because a core pack is for feeding. All right. Patients with ileostomies are at risk for dehydration and electrolyte imbalances because remember what's really happening with the patient that has an ileostomy. It's diarrhea in a bag, okay? And it's for the rest of their life, which is why we say monitor them closely and really check on them frequently and see how they're doing. Hemorrhage is going to cause dehydration because blood volume is volume of fluid, and fluid goes when blood goes, and there you go with hypovolemia. Okay, so your patient, they may not say dehydrated, but they certainly would say hypovolemia with a patient that is hemorrhaging. And I want you to remember this with post-op patients. In fact, I'm going to put that on the board. I want you to remember post-op patients are also at risk for dehydration. After all, we did starve them after midnight, and we're getting better with that. We're starting to allow clear liquids. And we didn't have a spaghetti dinner waiting on them when they got out of surgery. And then during surgery, they're losing fluid and they're losing blood. So they're at risk for dehydration as well. Burns is probably the biggest one on a test for dehydration. There is massive fluid shifts, massive fluid loss with burns. You're losing fluid through the tissue. You also are developing blisters all over the body, and that's if you think of a blister as fluid in the interstitial space, that's not where we want it. That's not going to help our hydration status to have fluid in the interstitial area. That's not going to help us. We're going to talk about extracellular fluid and intracellular fluid in a minute, but burns have fluid in the interstitial component in the form of blisters throughout the body. That's your second-degree burns, as you know. Okay. Next here is draining wounds. Your patient has a stage 4, a stage 3, a stage 2, and they're all draining. Stage 2 might not be draining, but the 3 and the 4 definitely are. Well, they're losing water, they're losing fluid. And I have seen patients with numerous wounds, especially coming from a beautiful family trying their best to care for the patient at home and not knowing how, not having any resources or help. I have seen that. I've even seen that in a place where they should have had all the resources and help they can have, long-term care facility, and you got numerous wounds, okay? So that is huge, all right? Now, profuse diaphoresis. Remember, diuresis is urine. Diaphoresis is sweat. Profuse diaphoresis in your athletes or your people that work outside. We talked about that. Hyperventilation, your respiratory rate being high or even on a ventilator, and then fever. I want to keep these three together. Hopefully you're writing some things down. Profuse diaphoresis, hyperventilation, and fever. These three make up insensible water loss. It means I can't measure it. So I'll say it again. Profuse diaphoresis, sweating, hyperventilation, rapid breathing, and fever give us what we call insensible fluid loss, in which you cannot measure that. So that's what you got to remember. Insensible fluid loss or water loss, these three make up that issue. I also added at the bottom here, although it's not least, it's not the most, but it's not least, alcohol. Remember that alcohol and caffeine are diuretics, but alcohol is very dehydrating, extremely dehydrating. And the alcoholic very often will pee their pants and not even know it, especially at night. They'll pee the bed, right? So alcoholics are having polyuria because alcohol, and I really want you to write this down, alcohol suppresses ADH, anti-diuretic. So what does that mean? Anti-PP. If you suppress the anti-PP hormone, what are you doing now? You're peeing, because ADH meant you weren't peeing. If you suppress it like alcohol does, you are now peeing. They pee all the time. They're always looking for a bathroom. Okay? All right. Now, so this was a select all that apply for dehydration causes. All right, let's move on a little bit here, shall we? Let's look at complications. What could happen because dehydration was allowed to go on and on and on? And I want to add another one because I just thought of it. Okay. Complications from dehydration, select all, include acute kidney injury, which is just another way of saying renal failure. It's acute because it's usually reversible. Chronic kidney failure is not, takes about 20 years to develop, 10 to 20 years to develop. Acute kidney injury happens right away when you are running around here dehydrated. But why? Why did that have to happen? Well, because the patient who doesn't have any fluid in the body also doesn't have any blood pressure. You've got to remember what we always talk about in class. We often say that volume of fluid controls blood pressure. Blood pressure can go high or low depending on the volume. If there's too much volume, the blood pressure is going to go up. If there's no volume, the blood pressure is going to go down. Because when you talk about blood pressure, it requires blood perfusing. So blood pressure, BP, means blood perfusing kidneys and all the rest of the organs in your body. So if you don't have any blood volume, you don't have any blood pressure, and we say a Jay-Z rhyme, no BP, no PP. Meaning if you don't have any blood pressure, you don't have any kidneys either. No BP, no blood pressure, means no PP. And when you don't have kidneys, you can't make PP or urine. No BP, no PP. You got to know that for the rest of your life. So acute kidney injury, which is another way of saying acute renal failure, is one of the #1 complications. Another complication, because again, you have no blood pressure. And whenever there's no blood pressure, you are at risk for shock. What kind of shock? Common sense. Hypovolemic shock. Now, the next one's tricky because it depends on the electrolytes. Sometimes the type of dehydration that the patient has, salt and water follow each other out the door. And so if you have a low sodium, like you would with DI, right? Okay, DI. If you do, then you're going to have, forget I said that. If you have a low sodium because it went out the way with the water, if you do, and that's rare, by the way, and that would not be with DI. It would not be with DI. It's not. It's with SIADH. But if you did have a dehydration with low sodium as well as low water, then you could have seizures. Or if you just had any electrolyte kind of imbalance, you could have seizures. I hope that makes sense. So DI is high sodium. SIADH is low sodium. Now, I put seizures here as a complication. It is super rare because if you have a fluid volume deficit, you might have an electrolyte deficit. And if you did, then you are at risk for seizures. It's rare, so don't remember that as much as the other two. Now, I have a third one for you. Just think of if you have no water in the blood, like none, well, relatively speaking, you have very low volume of water in your blood. Wouldn't you agree the blood is thick? And wouldn't you agree that if it's thick, another word for that on the test is viscosity? Yeah, thick blood is viscous, sticky blood. And thick, viscous blood is sticky and doesn't move really well. And blood that doesn't move really well and is sticky and thick and viscous or high viscosity is called high osmolality or osmolarity. So thick, viscosity, osmolarity, osmolality, viscosity, all that stuff means the blood could, guess what? Clot. The patient could throw a clot. This is why a lot of your athletes are throwing some clots. You're thinking, well, they're moving. I thought the way to, you know, prevent a clot is to move. Well, they're moving all right, and they're doing a lot of profuse diaphoresing. And then they get on that airplane to fly back home or fly to the next game or whatever. And they're sitting in the airplane for hours. Yeah, and they just sweated it out, or they drank a lot. Are you seeing how we could get to a problem? Just, you know, use your imagination. So AKI, renal failure, hypovolemic shock, and clots, and to a lesser extent seizures, are complications of dehydration or hypovolemia. Now, when we look at signs and symptoms, when we actually look at signs and symptoms, we have here that chart I told you will come in handy when you go and take your test, and there's a case study, because they like to do the bow tie and the case study stuff with this. So I'm hoping this helps you. So what I did is whenever I do this chart like this, and you know there's a lot of videos with this chart like this, whenever I do this chart like this, we're talking fluid volume deficit versus fluid volume excess. Now this video was select all that apply on dehydration or fluid volume deficit. There's a whole nother video for this one. So the only point of putting this up on the board under fluid volume excess is just to show the difference. And for the most part, there are a lot of opposites, not entirely, but for the most part, there's a ton of opposites. So come with me, watch this. Fluid volume deficit versus fluid volume excess, signs and symptoms. The one thing that they both share, and you got to write this down, the one thing that they both share is tachycardia. They both have fast heart rates, trying to compensate in this one, trying to push blood around faster throughout the body. But in this one, you're just causing the heart to work harder because there's so much fluid, and it is trying to push it, but you're just overworking the heart. So again, both fluid volume deficit, dehydration, and fluid volume excess or overload or retention, fluid retention, whatever way you want to say it, both of these share one thing and one thing only, and that is tachycardia. But look, y'all, and it's always on a test. I'll give you my word. This patient's quality of their pulse is weak and thready. In fact, they're difficult to find a vein in. When they come through your ER, you can hardly find a vein. Okay, it's like, oh my God, they came in here with no veins. So I'm going to show you real quickly. I don't know if it shows up on the video, but if you were to look at this, I don't know, shit. If you were to look at my arm, I just don't know if you can see that. But anyway, I got good veins, okay? I got a nice juicy one right there. Right there, okay? I don't know if you could see that. That's probably a waste of time. But what I'm trying to show you is if you go to put an IV in that vein, it's so easy, okay? But this patient's veins are weak and thready, and I can barely find a vein to put the IV in. This patient's veins are bulging, and the quality of the pulse is bounding. Oh, and they share one more thing. I said one. Okay, I lied. Two things. Tachycardia and increased respirations. Tachycardia and increased respirations. So the pulse or the heart rate and the respirators are high for both of these guys. And then everything else is kind of different. Okay, so here we go. Weak and thready, fast pulse, bounding fast pulse, breathing fast to get more oxygen to perfuse the body, breathing fast because fluid is heavy to move and it takes a lot of oxygen to move it, low BP and dizzy, high BP with a headache, totally different. I'm going to say that again because you give a darn. Low BP and dizzy, high BP and headache. Now, if you remember, we did select alls for your shock, for your precautions and different things. And you may remember me talking about neurosystem. and specifically making sure that you know with the neuro system that it's always high blood pressure, and if there's high blood pressure, it's always a headache attached to it. The same is true here. If there's a low blood pressure, dizziness or even syncope is always attached to it. All right, flat neck veins, especially when lying down. Jugular vein distension, distended neck veins, total opposite, right? Fluid volume deficit, you ain't gonna see no veins. I told you barely can find a vein for IV. Poor or decreased skin turgor is the exact opposite of edema. So fluid volume deficit or dehydration, poor skin turgor or decreased skin turgor. Remember, on the elderly patient, you check the sternum. Some people say forehead. Your test might say sternum, right? Pinch the sternum, because this is a waste of time on the elderly, right? Pinching and tenting is a waste of time. Weight loss versus weight gain. Oh, you know we're going to spend a lot of time on that, right? Okay, so get your pen, honey. Colored pens, I told you. Now, with weights, you already know that the patient's weight is going to change first. Literally, it is the most sensitive indicator of a change in the fluid balance. When we look at weight loss, we want to remember that 2.2 pounds equals 1 liter of fluid loss. I'm going to say that again. 2.2 pounds equals 1 liter of fluid loss. That's how you got to look at it when they lose that weight. And it's all of a sudden weight loss. Now, if we're talking weight gain, you know from school, nursing school, that you were taught to tell the patient to call you if they gain more than 3 pounds in a day or 5 pounds in a week. Common sense. You know this. I'm just making sure I pound it in your head so you know it for your test. Next on the list is specific gravity. Remember how the meaning of the word gravity is weight? Okay. This patient has a high specific gravity because if you take a cup and you pour water in it and you put a teaspoon of salt in that cup of water, then the salt or solute in the cup doesn't weigh anything because you diluted it. In this case, you put the teaspoon of salt in the cup and you took the water out. The salt is heavy. The solute is heavy. The urine is dark, not dilute. It's dark, concentrated. High specific gravity is always dark, concentrated urine, often with an odor. That's the dehydrated patient. The patient with fluid volume excess or fluid retention is going to have a decreased specific gravity and very pale urine. The patient's blood, as we spent a lot of time with this video saying earlier, is thick. We use the word viscous, we use the word osmolarity and osmolality. You need to remember that because the hemoglobin and hematocrit are going to be high. That is called, quote me, that is called hemoconcentration. On this side, there's so much water in the body that the hemoglobin and hematocrit are dilute, and that's called hemodilution. The blood urea nitrogen, the waste products in the blood. The blood urea nitrogen, waste products in the blood. Since you don't have any water, the waste products are in there and they're not going anywhere because you can't pee them out. So the BUN, or the blood urea nitrogen, is high. Dehydrated patients have a high blood urea nitrogen. Patients with fluid volume overload or fluid volume excess have a low blood urea nitrogen. The next part says positive orthostatics or postural hypotension. Listen up. As a nurse, you are very often given an order to do orthostatics on a patient. In order to do this correctly, you lay the patient down, you do the blood pressure and the pulse. You sit the patient up, you do the blood pressure and the pulse. And then you stand the patient up and you do the blood pressure and the pulse. If the systolic blood pressure drops more than 20 beats, the patient is positive orthostatics. So they're laying down, and by the time they stand up, that blood pressure drops. This patient with positive orthostatics or postural hypotension is at risk for falls. They automatically get falls precautions. Here, it's not an opposite, it's just something you have to know. This patient's at risk for seizures and high ICP. Prolonged capillary refill, you press and the blood does not return, because when you have low volume of blood or low volume of water, you don't have great perfusion. So the blood does not return to the body's tissues right away. So prolonged capillary refill. The patient is often constipated, might be the earliest sign. Patient is often constipated. They're definitely thirsty, unless they're the elderly and they lose their thirst reflex. They're definitely thirsty. They have warm, dry skin and an elevated temperature. Warm, dry skin and a slightly elevated temperature, maybe 99, maybe 100. Not fever, that's an infection. I'm just talking about the dehydrated patient will have a slightly increased temperature. They may be confused. That's a late sign, but they could be. On this side, the patient has crackles, pulmonary edema, which is pink, frothy sputum. They have shortness of breath and dyspnea because it's hard work to push all this fluid around, and the fluid may be in the lungs, causing the effort of breathing to be less and just having to work hard at breathing, right? Okay. They're restless because they're having shortness of breath, and as you know, restlessness can be hand in glove with respiratory issues. Okay, here the patient with the dry, dehydrated body has cracked, dry lips, even fissures and also furrows in their tongue, sticky saliva, right? And a low central venous pressure, CVP, a low central venous pressure. This patient has a high central venous pressure. And don't forget, I often teach you when you're thinking about CVP, central volume pressure. CVP just measures fluid in the body. Central venous pressure, volume of fluid in venous return. Okay? When we think about babies, and you know you got to think about babies, the baby may have a sunken fontanelle and absolutely no tears when they're dehydrated. Oh, I think you better write that down. Sunken fontanelles and no tears for babies versus bulging fontanelles and perhaps, you know, all kinds of trouble with that, because we're talking ICP now, right? Okay. Now, I want you to see something. It's going to be a little hard, but not that bad. First of all, diagnosis is a lot of different things. There's no one diagnostic test for dehydration. You're looking at the CBC, complete blood count. You're looking at the CBC for the hemoglobin and hematocrit, they'll be high. The BMP, your basic metabolic panel, is electrolytes, renal function, and glucose. Here, the renal function, the BUN will be high. the electrolytes will be wherever they want to be. Depends on what the problem was in the first place. The signs and symptoms of the patient should help, and their history. And then, of course, specific gravity of the urine. Now, let's look at the body's normal fluid makeup. Let's do that. You have two components of fluid. One is extracellular fluid that breaks down further into two types. And this is 1/3 of your bodily fluids. So 1/3 of all the fluid in your body is extracellular. Intracellular fluid is 2/3. So 2/3 of all the fluid in your body is inside of the cell. Now, I don't know if you can see it, but I'm going to pull you a little closer and pray that you can, because I really want you to see this, okay, y'all? I want you to see my little holy hookup. This is a blood vessel. This is a blood vessel. These are little red blood cells. The black letters in each little red blood cell is a K for potassium, because the most abundant intracellular electrolyte is potassium. Outside the cell, but inside the vessel, is called intravascular plasma. So all of this fluid inside this blood vessel is called plasma. In the plasma, you also have something called albumin, which is yellow on this, and it's really yellow in real life, but it's yellow on my board. Albumin is in everybody's blood vessel to keep fluid inside of it. So if you have a patient who's an alcoholic and has liver disease or has some other reason to have cirrhosis, if you have that kind of patient, their liver is malfunctioning. It's not going to make albumin out of the protein that the patient eats. That's why the patient with cirrhosis doesn't have any blood in their blood vessels, and instead it's in their peritoneal cavity, because they don't have any albumin to keep it in. So when we do a paracentesis and take the fluid off, we give them albumin. Making sense? Now, sodium is in blue. Salt and water go together. So in the plasma is sodium. It's extracellular. It's not inside the cell. Potassium is. It's extracellular. So when you lose water, you lose sodium. Now look at this. This is my blood vessel. Again, I'm trying, y'all. I'm trying to show you this damn blood vessel. This is my blood vessel. It's kind of blue. I don't know if you can see it. I don't know. Probably hungry anyway. That's my blood vessel. But outside of my blood vessel is something called interstitial fluid. Now, if the fluid is in the interstitial spaces, that's called edema, or third spacing, because the first space, the second space, the third space. Okay? So third spacing. Either you were in the cell, outside the cell, or outside the vessel. Intracellular, intravascular, interstitial. Okay. I hope you understand that. That was a little tricky. Okay, now, so let's go back a little bit and talk about nursing, because you knew we had to do it. Don't be acting brand new. You knew you had to know what the hell to do with the patient, now that you figured out they behind is dehydrated. So if you look a little bit over here, your nursing care, whoops, come on over on this side. The nursing care of this patient, the most important thing you must do with the dehydrated patient is daily weights. Strict I's and O's. Start that IV, get some IV fluids going, or at least oral rehydration if it's mild. Implement false precautions. Teach the patient to rise slowly. Now, I want to say something else about the IV. You know there's something called hypertonic, isotonic, and hypotonic, and you know, that whole thing. And that's a whole nother video, believe me. But the other thing I wanted to say about the IV is the guidelines have changed with the IV. We used to say always put an 18 gauge in the adult patient. Well, that's only if you're going to give blood. This can be a 22. It can be a 20. It could even be a 24 if you just can't find a vein. And remember what I said, it's kind of hard to find a vein. Now, if the cause of the dehydration is the hemorrhage, then you absolutely will need an 18 gauge. Now, I promised you that we're going to have a lot of fun. Here's the deal. What you got to know is that I have a couple of new things coming forward in 2025. The Oh My God packet has completely changed. Not completely, but it's changed. Obviously, the core information is critical, so it can't change that much, but it's been updated and revised because that's what I do. I go by what do I need to update, what do I need to revise, how do I need to better prepare students to pass the test, because my name is out there and you always pass, and I want to keep that up because it's been working for me. And then also we have some new packages. Some of you may have taken advantage of them. It's the LPN bundle that's specifically geared towards the LPN. We also have the new playlist called Select All That Apply. We also will have, here's the treat, you've been waiting, boot camp is 3 days. The next one is, just in case you can't see it, the next boot camp is January 17th, January 18th, January 19th. The next boot camp is February 28th, March 1st, March 2nd. Everybody always asks, do you do Zoom? No, I don't. But what I did do is I recorded the first day of the boot camp. And the boot camp day 1 is now available for purchase. Now, I don't know if you remember, but for Christmas, I gave it to you free, and it will be shutting down as of midnight. And the only way you can get those incredible videos will be to purchase them. So you have some time. Now, what you got to remember about day 1 of boot camp is that it's going through your Oh My God packet 1 page at a time. And so it's helping you understand the Oh My God packet. So the Oh My God packet together with the first day of boot camp, because you already know that 3 days of boot camp is $399. The Oh My God packet with the first day of boot camp is $129. That's it. That was my surprise. If you need anything or you need more information about that day 1 of boot camp, which goes through the Oh My God packet in great length, text me 216-410-0936. Otherwise, Happy New Year! Love you. Mwah! Be safe. No DUIs. Do you hear me? I will come up your street, down your parking lot, pull your hair, shank you in your kidney, punch you in your throat. No DUIs. It's the #1 case nurses catch. Just thought I'd throw that in for good measure because y'all are my babies.